Hello, my name is James Gill, and this is a trial that I'm doing at the moment with Elsevier about Macleod's clinical examination. As some of you may know, I have over the past recorded some YouTube videos for Warwick Medical School about the clinical examinations students and doctors at large are normally required to perform on patients. Those videos were designed as revision tools to augment the clinical skills teaching at Warwick Medical School. The one problem with videos such as that is that they require quiet. They require you to sit down and actually watch the thing. And if you've got some understanding about what's going on, all the better. The thing that they're not particularly useful is original learning, i.e. if you've never done a clinical examination before, they don't really show you what, and more importantly, why I was doing those particular examinations, those particular movements on the patient. So I've looked at what podcasts and things are available for medical students, and the area of clinical skills is one area that hasn't had a lot of things put to it yet. So I thought I'd attempt it. And then it comes to the question, what are you going to do? How are you going to deal with what is a huge topic? How to examine the human body? And then I thought, actually, I'd do the same as I've been doing with the clinical skills videos. I'd use Macleod's clinical examinations as my baseline, as it was when I was at medical school myself, and essentially try and record it. I listen to vast numbers of audiobooks when I'm in the driving seat, when I'm going for a run, when I'm cycling the bike, indoors that is. And I thought, fine, let's record Macleod's clinical examination. But I do appreciate that having some dodgy doctor just reading a textbook at a computer screen, to be honest, is probably going to be a good way to put people to sleep. So whilst I am going to read Macleod's clinical examination, I'm going to throw my sixth penneth in, as it were, talk about my examples clinically, my methods of learning some of the things in there, and I just thought the actual textbook itself would give a very good structure to a series of podcasts. As with all such things in life, just because I've had an idea, and I do have a few of them, doesn't necessarily mean it's going to be any good. So what I need to do is a favour from yourself, dear listener. Drop me a comment in the feedback. Tell me, am I completely wasting my, and then more importantly, your time? Is this something that you'd find useful? Is this something that you'd prefer less of James and more of the people who've written Macleod's? Ultimately, this is going to be chapter 1, which, as I look at the book here, covers 4 pages, so it's not going to be a particularly long exercise in listening, but it should provide a nice introduction and give us something to work with over the next few weeks. So, without further ado, here we go. Macleod's clinical examination, chapter 1. Probably should have some music here or something like that, but we'll do that in the past. Imagine that there's some music going on at this point. Okay, so chapter 1, approach to the patient, being a good doctor. From your first day as a student, you have professional obligations placed upon you by the public, the law, and your colleagues, which will continue throughout your working life. I note that he doesn't make any comment about your parents and friends, but hey. Patients want more than merely intellectual and technical proficiency. To be a good doctor or nurse is much easier if you genuinely like and are interested in people. Most patients want a doctor who listens to them, and the over 70 separate qualities have been listed as being important. Fundamentally, though, we all want doctors who are, here's the first list, knowledgeable, respect people, healthy or ill, regardless of who they are, support patients and their loved ones when and where needed, are always courteous, asks questions, lets people talk, and listens to them carefully. I think that's probably one of the most important things so far. Not that there's been much said so far. The reason being is that 90% of all complaints in the clinical setting are actually due to communication issues. I'll return to the list now. Promote health as well as treat disease. Give unbiased advice, letting people participate actively in all decisions related to their health and healthcare, assessing each situation carefully and help whatever the situation may be. Use evidence as a tool, not as a determinant of practice. Now that's a really crucial one, and it comes back frequently to when you've got the patient in front of you, even if you've got a slightly deranged blood level that you're talking about. Who are you treating? Are you treating the patient or are you treating the computer? And I think it's very important that sometimes, like using evidence as a tool, we don't forget that we're not treating a disease, but we're actually treating the patient. And part of that, as the next bullet point says, is humbly accept death as an important part of life and help people make the best possible arrangements when death is close. Work cooperatively with other members of healthcare teams, and finally are proactive advocates for their patients, mentors for other health professionals, and are ready to learn from others regardless of their age, role or status. Sounds simple enough, they should all be doctors. A doctor also needs a balanced life and to care for themselves and their families. This is something that we're seeing more and more in the healthcare profession, the issues with burnout, and people need to find their own ways, both at medical school and in their career overall, of how to survive and how to be able to deal with the rigours that are the job, the learning that you have to do, and the pressures that patients put on you. In short, we want doctors who are happy and healthy, caring and competent, and who care for people throughout their life. One way to reconcile these expectations with your inexperience and incomplete knowledge or skills is to put yourself in the situation of the patient and or the relatives. We're going to call that empathy. Consider how you would wish to be cared for in the patient's situation, acknowledging that you are different and your preferences may not be the same. Most clinicians approach and care for patients differently once they have their own or relative experiences as a patient. I've personally seen that myself. I've had various breaks and bones and things cycling over the years, and having seen the way that the orthopaedic team can treat certain new injuries, I think I've changed my practice a lot. I no longer see a walking injury, I actually see a patient who's injured. Doctors, nurses and everyone involved in healthcare will have a profound influence on how a patient experiences their illness and their sense of dignity. When you're dealing with patients, always consider the ABCs. Your attitude, how would I feel in this patient's situation? Your behaviour, always treat patients with kindness and respect. Compassion, recognise the human story that accompanies each illness. Dialogue, listen to and acknowledge the patient. Confidentiality and consent. As a student and as a doctor or nurse, you will be given private and intimate information about patients and their families. This information is confidential, even after the patient's death. This is a general rule, although its legal application varies between countries. In the UK, the following guidelines issued by the General Medical Council are in the above box, so I better find the above box. Duties of a registered doctor. The care of your patient is your first concern. Protect and promote the health of patients and the public. Provide a good standard of practice and care, keeping your professional knowledge and skills up to date. Recognise and work within the limits of your competence. And part of that is being able to say to a patient, I don't know. That's actually quite powerful because it brings you and the patient to the same level and actually lets you then go and find the best way to treat your patient. Work with colleagues to serve your patient's interests best. Treat patients as individuals and respect their dignity. Treat patients politely and considerately. Respect patient confidentiality. Work in partnership with the patient. Listen to your patient and respond to their concerns and preferences. Give information in a way that they can understand. Respect their right to reach decisions with you about their care. And this is me here. Allow the patient to make their own decisions, even if you don't think they're the best or the wisest option. As long as the patient's been informed by yourself, it's their body and they have the right to make the decision that they want. Support patients in caring for themselves to improve and maintain their health. Be honest and open and act with integrity. Act without delay if you have good reason to believe that you or a colleague may be putting patients at risk. Never discriminate unfairly about patients or colleagues. Never abuse your patients or the public's trust in you or the profession. There are exceptions to the general rules governing patient confidentiality, where failure to disclose information would put the patient or someone else at risk of death or serious harm, or where disclosure might assist in the prevention, detection, or prosecution of a serious crime. If you find yourself in this situation, contact the senior doctor in charge of the patient's care immediately and inform him or her of the situation. That might seem a bit of a strange thing to read, but I assure you, as soon as the curtains are closed or the doctor's consultation room door closes, patients will open up to you in ways that you cannot comprehend right now. The things that people will tell you, the joys, the sadnesses, and the crevices of their soul that they'll be prepared to bear to you because they need someone to speak to. And I think that that's something that as doctors we can't in any way diminish. Take all reasonable steps to ensure that the consultation and examination of a patient is private. As I say, you need to shut that door and make sure it's private. Never discuss patients where you can be overheard or leave patients' records either on paper or on screen where they can be seen by other patients, unauthorised staff or the public. Always obtain consent or other valid authority before undertaking any examination or investigation, providing treatment or involving patients in teaching or research. I'd probably argue that that's one of the most fundamental parts of the doctor-patient interaction. Even when it comes to taking a history, it's, would you mind if I asked some questions of you? You're gaining that consent to have the conversation with the patient about potentially difficult topics. When you want to do something which currently you might consider innocuous, such as listening to your patient's chest, you're still coming into their personal space. And so asking for that consent, asking for that patient's permission to have that conversation or just put a stethoscope on somebody's chest is of paramount importance. And if nothing else, it's going to show respect to the patient and help you build the consultation and the rapport with the patient at that time. Even when you've been given consent to disclose information about the patient, only disclose what is being asked for. So a good example there might be filling in an insurance report for a patient. If you have any doubts, discuss your report with the patient so that he or she is clear about what information is going to a third party. Clearly record your findings in the patient's case notes immediately after the consultation. These case notes are confidential and must be recorded and stored securely. They constitute a legal document that could be used in a court of law. I remember in my second year, the first time I actually got into the hospitals to see a real life patient, and the consultant, Miss Marshall, a fabulous vascular surgeon, she gave us the patient notes and said, right, go over there, take a history and write everything in the notes. It's like, but we can't write in the notes. We're medical students. This is hugely important. And she looked at me and said, yeah, you're medical students. Get on and write in the notes. It's important. So I think that highlights how important the medical notes are, that even though we were astonished to be writing in them, we were having an interaction with the patient and we were taking a history from them. That was still a legal thing and needed to be documented appropriately. Keeping accurate and up-to-date case notes is an essential part of good patient care. Remember that what you write might be seen by the patient, as in many countries, including the UK, the patient can ask for and receive access to their medical records. In years gone by, things have been written in medical records which patients would be less than happy to have had written about them. Certainly activities like that would never take place today, thankfully. Personal responsibilities. Always look after yourself and maintain your own health. Register with a general practitioner. Do not self-diagnose and self-treat. Yeah, good luck with that one at medical school. Certainly, you're not going to be able to self-treat because, well, you can't self-prescribe yourself things. But every single student that I have known, whilst a student myself, and subsequently now as a teacher of students, has a horrible habit of self-diagnosing and catastrophizing. And it tends to come directly after a clinical skills session. For example, we'll do something on orthopedics, and the following week I'll be dealing with 5 students who think that they've all got patellar tendonitis, they've got arthritis of the hips, and there's one who's worried about rheumatoid arthritis. And that's why we say at medical school, make sure you've registered with a general practitioner. Because along with the tens of students who are worried that they have a condition which they've just read about, there's always one in every year who we do ask to see their own general practitioner. But note, we tell them to go and see their registered doctor. We don't sort them out in clinic there because we don't know, and the student doesn't know either. And you must make sure that you don't treat your friends, and similarly, like your students, you make sure that proper channels are followed. If you know or think that you might have a serious condition you could pass on to patients, or if your judgment or performance could be affected by a condition or its treatment, you must consult your GP and be guided as to the need for a secondary referral. Heed your doctor's advice regarding investigations, treatment, and changes to your working practice. Protect yourself, your patients, and your colleagues by being immunised against common but serious communicable diseases where vaccines are available, e.g. hepatitis B. As a result of running off and doing mountain medicine and various things like that, I think I've had just about every vaccination available under the sun. And to be honest, a bit of a slight concern about my own health. My opinion on vaccines and similar treatments at medical school was always, if it's available, take it. Your professional position is a privileged one. Do not use it to establish or pursue a sexual or improper emotional relationship with a patient or someone close to the patient. Do not give medical care to anyone with whom you have a close personal relationship. Do not express your personal beliefs, including political, religious, or moral ones, to your patients in ways that exploit their vulnerability or could cause them distress. With that, I do think that there is something to be said for sharing a small amount of personal information with the patient when talking about a case. You can talk about your own experiences and things like that, if it will be beneficial for the patient. You've got to remember that at all times, the patient is the focus of your consultation, the focus of your history, and your overarching duty, your overarching aim is going to be helping that person and improving their care. Dress and demeanour. Yeah, sharp intake of breath here. I've seen some of the things that people in my year wore at medical school. The way you dress is important in establishing a successful patient-doctor relationship. Your dress style and demeanour should never make your patient or colleagues uncomfortable or distract them. Smart, sensitive, and modest dress is appropriate. Expressing your personality is not. Exposing your chest, midriff, and legs may not only create offence, but impede communication. Have short or 3/4 length sleeves, or roll sleeves up away from your wrists before examining the patients or carrying out procedures. I'd also add to that, essentially make sure that you are bare below the elbow. That means removing watches, bangles, or anything else that you might have. Having bare below the elbows allows you to clean your hands effectively and reduces the risk of cross-infection. Whilst antibiotics are considered to be one of the most amazing things for 21st century medicine, perhaps one of the biggest leaps forward we had in medicine was much more simple. Soap and soup, making sure that you are cleaning your hands, reduce the spread of transmission between patients, and making sure that patients were adequately provided with nutrition in order to be able to recover also improved mortality rates greatly. Tie back long hair and keep jewellery simple and limited to allow effective hand washing. Some medical schools and hospitals require students and staff to wear white coats, not in the UK, or scrubs for reasons of professionalism, identification, and as a barrier to infection. If this is the case, these must be kept clean and smart, and you should always wear a name badge which can be easily read, i.e. not at your waist. Whenever you see a patient or relative, introduce yourself fully and clearly. A friendly smile helps to put your patients at ease. When I was focusing on communication skills, that was one of the bits of feedback I always used to have. James, smile a little bit more. You're looking far too intense. You'll scare the patient away. And actually, that small thing, just opening the consultation, hello, my name's Dr. Gill, smile, how can I help, has actually improved things tremendously for me. How you speak and address a patient depends on the patient's age, background, and cultural environment. Many older patients prefer not to be called by their first name, and it's best to ask patients how they would prefer to be addressed. And in my experience, going with sir or ma'am is never really going to get you in trouble. Although that said, I did once have to treat a lord and lady, and did go into the cubicle and say, oh, terribly sorry, they've clearly made a mistake on the paperwork here. It says you're lord and lady, whatever your name is. Of course you're not, you're far too normal for that. They looked at me and said, well, we're terribly sorry, doctor, but we are actually lord and lady. We just don't like to shout about it. So make sure you know exactly who it is you're pulling in for your consultation before you start. Communication skills. A consultation is a meeting of two experts, you as the clinician and the patient as an expert on his or her own body and mind. Excellent communication skills allows you to identify a patient's problem rapidly and accurately and improve patient satisfaction. Poor communication skills are associated with increased medical legal vulnerability and clinician burnout. There we go, didn't I say that right at the beginning? Clearly something that was taught to me at Warwick went in. Improve your skills by videoing yourself consulting with patients, having obviously obtained signed consent. And when you do the videoing, looking back at yourself, try not to be too distressed about your own voice. I know I absolutely hate the sound of myself recorded. He says recording a podcast. As you can tell, I'm probably not going to listen to this back. And review this with your senior clinician using one of the many techniques developed for this sort of review. Continually seek to improve your communication skills. These will develop with experience but can always be improved. Most doctors and nurses work in teams with colleagues in other professions. Working in teams does not change your personal accountability for your conduct and the care you provide. Try to act as a positive role model and motivate and inspire your colleagues. Always respect the skills and contributions of your colleagues and communicate effectively with them, particularly when handing over care. Expectations and respect. The literary and media stereotypes of doctors frequently involve miraculous institutions, the confirmation of rare and brilliant diagnoses, and the performance of dramatic life-saving interventions. And in the case of House, a surly demeanour and a walking cane. Sorry, I think House is absolutely terrific, but each to their own. I actually learnt a lot from House. I think it's a great way of taking a mental break from study whilst also still keeping medicine fresh in your head. You can kind of play that diagnose the patient game before he does. Anyway, the reality is different. Medicine often involves seeing and treating patients with common conditions and chronic diseases where we may only be able to provide palliation or simply bear witness to a patient's suffering. The best doctors are humble and recognise that humans are infinitely more complex, demanding and fascinating than one can imagine. They understand that much so-called medical wisdom is at best incomplete and often simply wrong. One of the things I think they told us toward the end of medical school was when you graduate from medical school, 10% of what you were told was out of date. By the time you complete your specialty training, 25% of what you were told at medical school is out of date. And by the time you retire, that can have risen to up to 50% of the information you were given is now outdated. Which in some ways isn't too bad. We don't have to carry around leeches anymore. Not that I'm saying I did. I graduated in 2010. We didn't use leeches down there. Although I have seen patients using maggots before, but let's not go there at this precise moment in time. I'm sure we'll talk about something like that when we discuss about reviewing wounds. If a patient under your care has suffered harm or distress, act immediately to put matters right, if it is possible. Apologise and explain fully and promptly to the patient what has happened and the likely effects. Patient complaints about their care or treatment are often the result of a breakdown in communication. See, it's so important. It's been discussed 3 times now, and we're only on page 3 of Macleod's. And patients have the right to respect a prompt, open, constructive and honest response. Do not allow a patient's complaints to adversely affect the care or treatment you provide. One of the things that I've found that goes an awful long way in any situation is a simple, honest, I'm sorry. We've all done small things, dropped the ball at times, called in the wrong patient's name, something like that, or in my case, mangled a patient's surname. A simple sorry and a heartfelt smile with it can go a long way to smoothing over those cracks. Hand washing and cleanliness. Transmission of microorganisms from hands of healthcare workers is the main source of cross-infection. In hospitals, primary care surgeries and nursing homes, healthcare-acquired infections complicate up to 10% of hospital admissions, and in the UK, 5,000 people die from them each year. Hand washing is the single most effective way to prevent the spread of infection. It is your responsibility to prevent the spread of infection and routinely wash your hands after every clinical examination. Do not be put off by lack of hand hygiene agents or facilities for hand washing or being short of time. If your hands are visibly soiled, wash thoroughly with soap and water. If your hands are not obviously dirty, wash with soap and water or use an alcohol-based rub or gel. Note that for something like DMV, rotavirus, the alcohol won't protect patients against that virus. You need to go back to that good old-fashioned soap and water. Always wear surgical gloves when you may be in contact with blood, mucous membranes, or non-intact skin. Whilst washing with alcohol-based gels will remove most microorganisms, but will be ineffective against viruses such as influenza and norovirus. Okay, that's the end of chapter 1 of Macleod's. So, what do you guys think? It's taken 27 minutes to get 4 pages into this, and if we exclude the index, there are 439 pages in the book. I'm probably going to need to get more drinking water. But no, seriously, I'd be really grateful to know what it is that you guys think about this. Have I just wasted 27 minutes of your life? How many of you actually managed to survive more than the first 5 minutes before going off to, I don't know, watch videos of cats? And how many managed to not fall asleep? I'd be interested to know and see whether or not you think this is useful, whether or not you prefer me to just read it at rote, or whether or not my continual interjections provide a little bit of context for you. Yeah, we'll see how we go from there, but I'm going to leave this probably a week or so before I put up the next one, just to get some feedback to see what's going to be most beneficial to you guys. Because at the end of the day, I teach the clinical examinations. I'm always happy to have a brush up on it, but this is out there for you guys to sort of be able to, well, as I said, go running, listen to in the car when you're traveling, heck, fall asleep to, whatever. I'm rambling. Okay. Thank you very much for getting this far. Again, feel free to drop me in the comments and send me messages directly if you want to via Twitter. I'm literally at Dr. James Gill. Thank you. Good night. Or good day. Whichever. Okay, bye.